And this same concept was applied in GI. Again, in 2004, the University of Nebraska was looking to expand its GI service. And they had a target compensation rate of about $180,000, which is a lot of money to many of us. But then those same people were competing with a private practice target salary in Omaha of $600,000. How can you recruit to academic medicine when the numbers are so different? So academic medicine understands this and is making hybrid models where, for example, technical revenue is being shared, productivity models are being changed, because academic medicine would really die if this is what we have to compete with. Now, there are other ways that academicians in particular can sort of augment their salary. And there's speaking fees, consultant fees. Generally speaking, academic physicians tend to be fairly sought after by industry to provide comments on medications or procedures. Now, one needs to be very careful that if one does go into relationships like this, we maintain the highest levels of ethics and we don't alter the message based upon who's making payments. And it's also important to know that the Sunshine Act, which is going to be part of the Affordable Care Act, is going to make all of these relationships open. Before, this used to be behind the scenes, under the table. Some pharmaceutical companies are already releasing this data, and in 2013, they all will. You can't read this slide, but I put it up there for a reason. If you look in, you can see how one physician here has all of these salary lines come from various pharmaceutical companies. One gentleman on this list is making over $100,000 just speaking for pharmaceutical companies. So you have to think, how objective can you be if you're getting paid so much, and at the same time, do you want this information to be public? I would say don't do anything that you don't want plastered on the internet, because this is the real world. Student debt is another issue. Now, those of us who go through medical school, the vast majority will have significant debt. And if one has significant debt, we can't make future decisions in a vacuum regarding what our debt is. Now, what I tell my residents or my fellows is, look 5 to 10 years down the road and get some idea as to realistically what you need to earn in order to be happy. Now, from a resident, it's very easy because residents don't earn very much money, so even an academic salary is huge in comparison to a resident salary, but you have to be realistic. And if you can come up with that number, a realistic number, and you say, gosh, this cannot be met in academics, then don't try something which you know is going to fail. But at the same token, don't artificially increase this number so much that you're just not being fair to yourself. And make sure that you match your individual interests and personality traits with your work environment. Academic medicine has a lot to offer, so don't basically skip over it just because of salary issues. Now, what do residents value? This was a survey which shows that there's a change in what current residents are looking at for maybe how it was during my time or earlier. Free time is very important. And these types of lifestyle issues are very important. And if you're a private practitioner and you're your own boss and you have to run your own business, lifestyle may not be quite as easy as it's made out to be. So you don't need, again, the dichotomy of academic medicine versus private practice. You can be in private practice, but if you're an employed private practice physician, you may have some of the benefits of lifestyle and lack of need for business knowledge. Not that I say that what Khalik said was wrong. We should all understand the business of medicine, but it may be a little bit less important if you are not your own boss running your own practice. So I'm going to skip this slide. And I just want to talk about barriers to entry for a moment. In the old days, anybody could go into private practice. You didn't have to know anything about the business of medicine, and you could be highly successful. And the real question is why? And the simple answer is that margins in healthcare used to be so high that you could make multiple mistakes in business, you could learn on the job, and you still would have a net positive cash flow and you would be okay. But now, margins are much less. They're definitely there, but one needs to know what they're doing and have sound business plans before one moves forward with any sort of plan. And also in private practice, it's very difficult to start your own office in certain fields, such as ophthalmology, although I have to congratulate Bobber for doing so, because the cost of equipping your office is very high. So the startup costs raise a barrier in certain fields. Other areas, access to health plans and access to insurance panels. If a health system wants to block you, then it becomes very difficult for you to get access to those patients or to that hospital to see patients. Now, I'm going to change the focus of this talk for a few moments, and then I'll be done. I have no crystal ball, so I can't predict what's going to happen with healthcare reform or what's going to happen with the economy. But there are certain fiscal realities which we all need to understand. This is a graph showing what Social Security and Medicare, in essence, are taking in and what are the projected outlays. So whether you believe in the Democratic plan or the Republican plan or some plan that is as of yet not created, this slide shows that the status quo cannot exist because we're going to be paying out so much more than what we're taking in that it's unsustainable. So this will have fundamental changes in what happens to healthcare, and as providers, we will be at the epicenter of that fundamental change. So we need to understand that that change is coming. And let's just look at things from a business perspective. If you were Google or you were Microsoft, you need to present your financials in a certain way for the Securities and Exchange Commission to analyze it. If you're the federal government, you don't have to do any of that. So you really can spin things however you want. But if the federal government had to submit to a full and true audit, what are our liabilities? These are Medicare and Social Security's unfunded liabilities if we're going to pay out what we expect to pay out, combined with the intake of revenues that we expect to take. So over the next 80 years, and I know that seems like a big window, but when you're planning for governments, that's actually not a huge window. We have an $11.6 trillion unfunded mandate in just one part of Medicare, and a $24.8 trillion unfunded mandate in Medicare's Part B and D. So, you know, we're talking about trillion-dollar deficits, not that they're very good right now. These are orders of magnitude greater than that, and until we understand it, accept it, and make sound policy to change it, we're not going to be moving forward. This graph shows that assuming that the healthcare growth stays as it is, come 2082, 98.9% of our GDP will be in healthcare. I mean, that's impossible. It's unrealistic. It cannot happen. So the reason I'm telling you this is that changes will occur. Keep this in mind as we move forward. So the last couple of slides I want to talk about are, what is the future of medicine? I don't have as I said, I don't have a crystal ball, but hospitals and health systems are conglomerating. They're starting to get more market share. They're starting to, again, have some vertical integration. They're employing physicians more and more. Accountable care organizations, if they take off, which we don't know whether they will or not, may make being a solo practitioner a little bit challenging. Healthcare already is an oligopsony. Now, we may not know what that is from an economic term, but what it means is that there are few payers for what we provide. There are only a few insurance companies or Medicare that pay us for what we do, which means that in this marketplace, the buyers have significant control over what we do from a price point perspective. And if things change into the future and you have fewer payers, then they will have even more control over what we do. So independent physicians in small groups may be a little challenging. Employed physicians in large groups may come out of this. Now, this is how I see this landscape changing. You know, there are going to be private practice academicians, and these folks will be involved with clinical research. They will teach residents and students in their offices. They will collaborate with industry. They will self-fund their own research. Just like Khalik was self-funding his IMANA trips and his other things of importance to him, research will partially be self-funded off of the margins of people in private practice. And they may even create nonprofit arms in order to support these missions. And then there are going to be academic private practitioners, where you may be employed by a medical school or by a large health system. Your salary will be much more tied towards your productivity as opposed to being at an academic institution where you can sit back and sort of watch what happens. It's not going to be that way. If you don't work, you don't get paid. And there's going to be this mixed scorecard. Maybe you don't need to be a researcher, an educator, and a clinician, but you probably need to be at least two of those to succeed in this environment.